Hello everyone, this is Dr. Khan, Executive Plastic Surgery. Pleasure to be on another Facebook Live. This is going to be a very defined one where I want to go ahead. I get a lot of questions from a lot of patients, their significant others. What is it that we need to do? The first and foremost thing is informed consent. You have to educate yourself about what you're signing up for, what are the expectations, what are the goals of the surgery. So yesterday I did a recording of all the questions you should ask your plastic surgeon. So common questions to ask Dr. Khan, Explant surgery. Are you board certified? Are you an end block specialist? Do you put implants in? What type of facility? How many end block explants have you done? How long will the surgery take? Is your goal to remove all of the capsule tissue from the chest? Is your goal to remove the implant and capsule as one unit or as a whole? And a whole series of questions. How long do I wear the garment for? So I want you to be on the lookout. We are going to post this on the Facebook Live. This is what your surgeon must be discussing with you, all the details. So this is very important. Do your homework. This is part, again, of the informed consent. If you get any surgery, you should be doing your homework so that you know what the expectations are, what are the understandings that you have for the post-operative recovery. Now, I want to go ahead and mention that there's 5 things you must be actively considering and looking into. The first and foremost thing is you want to see the high definition pictures and videos of the chest wall showing complete removal of the capsule, and also part B of the implant and capsule cut open on the table. Not from one case out of the week, but your own case and the other patients, so they're doing a check and balance on their surgeon and certainly on me, so that we are able to, as a surgeon, tell you exactly what was done, and that we have high definition videos and pictures of the chest wall showing complete removal of the capsule. And this is the ultimate and the only proof that the surgery was done in the manner that it was described, with the right lighting, and then the physical evidence that the whole capsule was removed along with the all inflamed tissue, and also on the table cutting open of the implant capsule. The other thing I want to mention is your surgeon should not be augmenting, and not only the surgeon but the group as a whole, because within a group I have seen 2 surgeons. One is augmenting, the other one is explanting, so they can market that surgeon better. So you want to make sure your surgeon is not augmenting at all. In 2025, with the evidence we have, no surgeon should be doing any harm. And over the years I have seen that many surgeons have converted into explants only, and for very appropriate reasons. Do no harm. And you want to also make sure that, number 3, that you're talking to the surgeon directly. I talked to a patient from Minnesota earlier this week, and she mentioned that I talked to the group, and this is how the surgeon does it. I said, did you talk to the surgeon himself? And she said, no, I just talked to the nurse. And the nurse was telling me all these things. I said, I will tell you, the nurse does not know what's happening in the operating room. She's not the one who's doing the dissection or the surgery. I said, did you see the track record of the surgeon that he or she has done in the manner as described? And this goes on to the point number 4. Every explant surgeon should be an advocate, should be speaking for that capsule plus the implant, and all of that inflamed tissue must be removed completely, sincerely, definitively. They should be actively posting it on their website. We have a lot of surgeons doing that already, but they should be actively, vocally talking about it, such that they are patient advocates. Number 2, they're trying to raise awareness. And number 3, their previous patients are talking to each other. So I myself have a private breast implant knowledge support group where all my previous patients are talking to my prospective patients and authenticating the fact and confidently sharing that information, be it high definition pictures and videos, all that personal feedback, so that they only let the next group of patients know how the surgery was done. Was it truly as was discussed? Is this really what and how the surgeon does it consistently from one patient to the next? I find some surgeons have their medical assistant or their office manager or their PA, nurse practitioner, their nurse, someone other than them who are always there to answer questions. No, in my practice, I am the one who's talking to you from the very beginning to during the surgery and afterwards the recovery. And so it is very, very important to be talking directly to the surgeon before, during, and after. This is a surgery where you have to have a very much involved personal input, the confidence, one-on-one sharing with the surgeon so that you have that feedback. And this Facebook group should be allowing for the previous patients to be talking to their prospective patients, and that is in itself a check balance not only on me but on all those surgeons. There are some surgeons who say what happens in the consultation room stays within the consultation room. It should be just the opposite. What happens should be videotaped or shared or recorded, and transparency is very much key when it comes to the explant surgery. And this is overall, as you will see, after a period of time, you will get that contentment, that mental satisfaction, and from your heart you will be happy, from your mind you will be happy that you're signing up with a surgeon who's truly committed to completely, sincerely, faithfully removing not only the implant but the capsule and all of that inflamed tissue, preferably in what is the en bloc method, which is 100% total capsulectomy or 100% total capsulectomy, such that there is no spillage of the silicone. In my practice, and I'll end with this, the 𝐾ON procedure where the entire implant capsule is removed as en bloc fashion, or 100% total capsulectomy, where the need for the drain is not there. I've not put in drains in well over 5 years. The last time I did that was 2020. And the many ruptured implants that I have done, the 800cc ruptured, and a lot of it, because I never let the badness fall into the chest. I do not cut sharply through the chest, and there is no excessive weeping. I remove all of the capsular tissue, so the need for the drain is not there. Number two, no unnecessary lifts. Vast majority of the patients do not need that unnecessary lift. So between me removing that excess skin, which is that pseudo lift, and the internal sutures that I put that lift the breast tissue up, between the recoiling of the skin and the breast tissue, the younger you are, the more the tissue, the skin will recoil. If I take 10 centimeters of a skin for full thickness skin grafting, for example, on a burn patient, and I put it on the table, that 10 centimeter becomes 6 centimeters. So it becomes, on a young patient, becomes 6 centimeters. So it will shrink anywhere from 25, 30, 40%. So this is very important to take into fact. When the implants are sitting on the chest, there is a concavity effect, some more, some less. So that with the implants gone, the chest, the rib cage is going to extend out more like a round. This is how a normal chest is. And between the 10, 15, 20% muscle mass the patients adds to their chest, between the fluffing effect that occurs, because you have an implant in the proximity of the breast tissue atrophies, decreases, diminishes. With the implant gone, the breast tissue gets a chance. A year and a half out, the breast tissue blossoms, if you will, fluffs out. And between all of these, you will see the aesthetic result is indeed very much achieved, minus the unnecessary cut around the nipple areola. Number three, the implants are always returned to the patient. This is again part of the 𝐾ON procedure. Number four, the pathology is done where the capsules are sent to pathology to rule out that rare BIAL-CL CD30 analysis done, rule out breast cancer. Number five, cultures for aerobic, anaerobic, and fungal. Number six, twilight deep sedation, where the patients are not paralyzed. There is no ventilator breathing for the patient. There is no chance for any ventilator associated trauma. There is no chance or decreased, diminished chances to non-existent chances for getting a blood clot because the patient is not paralyzed. And all patients, regardless of their age, be it the 89-year-old patient I operated on 3 months ago or the young 22-year-old, they get the same surgery because everyone deserves world-class complete care as if they're the president. So there is no cut or compromise in someone who has a connective tissue disorder or a lupus or diabetic that you have to rush through the surgery and make it smaller. I do not touch the breast tissue that is above the muscle in the vast majority of the cases where the implants are below the muscle. Even in the many cases where the implant is above the muscle, I do not touch the breast tissue. I do not cut up and down or around the nipple areola because that is not warranted. So do your homework, do your research. You should feel that contentment from your heart and from your mind so that you know what you're signing up for. No two surgeons are the same. This is literally, I will end with this, on-the-job training for all of us. There is no textbook that will describe how it's done. The general consensus amongst the many plastic surgeons, be it in Europe, Canada, the US, is this is involved surgery. You bet it is involved. It has its risk of pneumothorax, among others. Yes, in trained hands, it absolutely can be done. And there are, when done right, this is still very much outpatient surgery. If you do your homework and your research and your network, this is the type of surgery that can be done safely, completely, definitively. If someone has their surgery done today, they have their peace of mind that all of the capsule is removed and all of it is tested. And likewise, the surgeon's mentality, mindset has to be firm that the post-operative recovery is dependent on the surgeon doing the complete, thorough, complete job of removing the implant capsule, all inflamed tissue, as one piece. It is what is the en bloc method or 100% total capsulectomy. And then the second thing is that the surgeon must be able to carry out that task, the responsibility of removing it. Many surgeons who even want to do it may not feel comfortable doing it when the going gets tough because they may not have the technical expertise into dissecting directly over the rib. In my practice, what ensures a complete en bloc or a total capsulectomy is where I remove not only the implant capsule, but the fascia of the intercostal muscle, the fascia of the serratus anterior, fascia of the pectoralis minor, the periosteum, perichondrium, such that all of that capsular burden is removed completely, sincerely, with definitive honesty, so that there is no second guessing the task. Hopefully you found this informative. There's a lot of information I discussed, but as you will see, initially you might be overwhelmed, but after some time, if you follow me on the Facebook Live, YouTube Live, TikTok Live, Instagram Live, you feel very comfortable that this is not too hard of a topic to grasp. There you have it. This is Dr. Khan, Executive Plastic Surgery.